Good morning, everybody, and thank you so much for coming to listen to my lecture on peptides, a basic understanding and application in clinical practice. I would have loved to be there with you, but unfortunately I was unable to. And I think that I'm available for questions afterwards. Peptides are really wonderful. I think some of you have gone to Dr. Holtorf doing the workshop I was supposed to do on Thursday, and I'm sure you learned a lot about peptides then. I'm looking forward to bringing you my perspective, which is from the Seed Scientific Research and Performance that I am a fellow of, and gratefully so, because we've been working together for 5 years and have learned a lot about peptides. And the clinical application of peptides is really an amazing improvement on helping people optimize their health and perform an optimal performance. I'm not just talking about athletes, but I'm talking about everybody, and about senescence, and as we get older, how to protect ourselves, because as we know, aging is pretty much something that we can change how the outcome is, and how, well, the outcome we can't because everybody will die, but how we can make people feel better, optimize their experience, and be participants and contributors to society as they get older. I will go through the science as quickly as possible, because I think the most important part of my talk is really the passion that I feel about using peptides in the practice after using hormones for 26 years and realizing how their impact on our health and preventing disease is tremendous. And writing about hormones, experiencing the clinical application of hormone usage, bioidentical hormones being obviously what I'm talking about primarily, and then thyroid, adrenal, and bringing peptides has brought another level of wellness. So I want to share with you everything I know in a very quick time frame, but you can find out more about what I do through the Seed Scientific Research Performance and our website, which is ES Health. So Evolved Science, we're in New York City, and we have a concierge medical practice, and our patients are really great and healthy. We're taking care of 600 patients, and we've had 10 positive COVIDs over the past year, and not one patient required hospitalization. So that should tell you not just about the fact that our patients are committed to their health, but the fact that our patients are getting the kind of support that keeps them healthy. And I would like to help you share with you all the information that we're using in our practice. So thank you so much for coming here today. Thank you. Next slide. So all starts with proteins, right? They're chains of over 150 amino acids. They are initially a direct copy of DNA, which I'm not sure everybody knows, but it's important to know. And they're modified in the cell nucleus or cytoplasm, wherever their effect goes to, by glycation, the pH, methylation, snipping, now the SNPs being the key to creating other important pieces of the protein, and pretty much taking you to peptides. Next. So peptides are less than 10 amino acid chains, and they're generally cleaved from the larger polypeptide or proteins after they leave the nucleus. They act as hormones, messengers, or as Dr. Turner, who's another fellow who's wonderful, coined the term foreman, because they oversee the expression of other proteins, peptides, and messengers. So peptides are really about messaging. So what are familiar peptides? Because pretty much you'll learn that everything's a peptide and everything's a hormone. So it's just a matter of realizing that we have a lot of terms to say the same thing. So familiar peptides are insulin, bacitracin, which is an antibacterial. We buy it at the at CVS, at the pharmacy, and nobody ever thinks that it's a antibacterial peptide. Oxytocin, big hormone, right? Well, they're all peptides. So next slide, please. So some peptides are hormones. And I think that this is a pretty important distinction because, as I said before, we use terms interchangeably. And I think it'd be really interesting if we understand that you can use them interchangeably, but what are they really referring to? So peptides are less than 50 amino acids. Polypeptides, which are more than one peptide, are proteins with more than 50 amino acids. What are examples of these? Are insulin, ADH, FSH, ACTH, ghrelin, glucagon, growth hormone, renin, TSH, not twice FSH. And then there are steroid hormones, which are made of lipids, and we'll address them in a second. But those are estrogen, progesterone, and testosterone, which are our gonadal hormones that we talk so much about and have so much controversy with. And then there's one other type of hormones, which are tyrosine-derived hormones, which are T3 and T4, and the adrenal catecholamines. Next, please. So what are steroid hormones? So steroid hormones are secretions of ductless glands. They're made from lipids with characteristic steroid ring structure. They're made from cholesterol. And we have this whole conversation going on all the time about that we need cholesterol to have hormones to be in balance. And our conventional counterparts don't understand that a cholesterol of 140 is not something great. It's not going to protect anybody's heart. It's not going to prevent atherosclerosis. It'll just age you quicker and kill you faster. So you need cholesterol. These steroid molecules that are made from cholesterol are all hydrophobic molecules. They're synthesized in the smooth endoplasmic reticulum, and they're synthesized as needed. Although they're delivered in pulses from the pituitary, or you will see that they aren't as needed. They're not sitting there on reserve. They attach to protein carrier for transport in the bloodstream. So SHBG, sex hormone binding globulin, that we know how it gets attached to testosterone. And as we get older, the level of SHBG goes up. And the hormones, it also, estrogen gets attached to it too. The hormones get indelibly and unseparated. They cannot be separated from SHBG. And so the availability of these hormones becomes lower as we get older. They have receptors on the cell surfaces. They do signaling effect change in the cell. They also serve as second messengers. Their action is slow and permanent. Examples of them are estrogen, testosterone, progesterone, cortisol, aldosterone. Next, please. So protein hormones, peptides, polypeptides, and proteins all also become hormones. So they're made up of amino acids plus minus other molecules, like they're hydroxylated, so they have hydroxyl groups. They're large or small hydrophilic molecules. So remember, the lipid-based molecules are hydrophobic, and these guys, the protein-based molecules, peptides, are hydrophilic molecules. They're synthesized in the rough endoplasmic reticulum. They're transferred to the Golgi apparatus and repackaged into vesicles to be secreted. They're stored until the signals are received for their secretion. They're freely transported through the bloodstream, and they have receptors inside the nucleus. They bind to DNA to modify transcription, and they have rapid and temporary actions. Examples are ADH, calcitonin, glutathione, bradykinin, angiotensin, vasopressin, oxytocin, and thyrotropin releasing hormone. Next, please. So there's one other type of hormones, as we said, which are tyrosine derivative hormones. Interestingly enough, they come from one amino acid, tyrosine. This amino acid is manipulated to make hormones, and they act either like a steroid hormone or like a protein hormone. So these are very interesting because the T3 and T4 hormones are in the thyroid are steroid-like, while the catecholamines in the adrenal medulla, which is epinephrine and norepinephrine, are protein and polypeptide behaving like. Next, please. So we all know that hormones decrease with aging. You know that at perimenopause, estrogen drops like a lead balloon, and progesterone drops even before because we don't have ovulatory cycles anymore. Testosterone drops, growth hormone drops, DHEA drops, melatonin drops. The most significant piece as far as what we can do to manipulate, to change that, is the growth hormone. And as growth hormone starts dropping, a lot of changes occur. It's not as precipitous a drop, but it's a significant drop. Next, please. So immunosenescence is really the key here because it's thymic involution occurs. It's like a decisive factor, and it's responsible for the inability to replace naive T cells as they're used up. So the naive T cells are really crucial to our immune system's function. And developmentally, this is programmed to start the involution actually starts after puberty because the T cells and our immune system are all geared up to get us to reproduce. And in order for us to reproduce, we have to survive to reproductive age and make it through reproductive age. The moment we're past reproductive age, we're useless. There is no purpose for us. And on the food chain, we have to start heading south. And I think it's really important to realize that the most decisive factor, really, one of the most decisive factors is the thymic involution that stops creating naive T cells. So once they're used, and they're going to be used because we're exposed to a lot of things developmentally and environmentally and in life in general, once they're gone, there's no more. And once we don't have any more, inflammation goes phagocytosis goes down, superoxide dismutase production goes down, everything starts, our neutrophils, macrophages, everything starts. Anything that can protect us from getting destroyed by anything outside of our bodies disappears. Next, please. So back to growth hormone, because growth hormone is probably the key, as far as we could tell, of this important orchestra that hormones are. So you saw how growth hormone slowly goes down. Well, by the time we get to growth hormone deficiency, we really don't even know that we got there because it's a very slow process. You saw how estrogen drops, testosterone drops, progesterone drops. Growth hormone slowly declines. So it's like being under a cloud and not knowing that there is blue sky above us. And when you go back to the other side of, you're no longer deficient, then you say, oh my God, I was feeling really badly before. But you don't know that because you're losing your sense of well-being. You feel less self-control. Depression and anxiety is there, and you immediately will go to the doctor and get some antidepressants because that's what you need. Some people experience intensified jet lag, but on the other hand, I've seen people who experience less jet lag as they get older and their growth hormone levels goes down because their immune system is so out of whack and their hormone balance is so out of whack that eventually they don't even know, their body doesn't even realize that there is circadian rhythm change. that is associated with the jet lag. So people become, as they're old, resistant to new ideas or situations. And we know that. I mean, you can't teach an old dog new tricks. Well, it's because their growth hormone is low. There's less lean body mass. There's more fat. So, as you know, muscle mass is crucial. Muscle is a really significantly active organ that keeps us young. And as you get older, you can't build muscle anymore because you're losing your growth hormone. And also you become sedentary, lifestyle change. But I don't know what comes first, the chicken or the egg. I mean, is it because people, as they get older, move less because they're just tired of moving? Or is it because the growth hormone comes down and the sense of well-being is tied into the amount of movement that each one of us makes? There is a decreased HDL and a higher LDL. And, HDL is the good lipid, and HDL has so many positive effects, and LDL is what everybody's trying to treat, but you're not going to be able to treat the high LDL with a statin. You develop a poor immune response, which kind of summarizes, it's the sum of all of this. Now, we know for the past 5 decades, people have been taking growth hormone, exogenous growth hormone. So the exogenous growth hormone was initially, for the anti-aging. Actually, it was initially for gonadal insufficiency when kids didn't grow, and that's how it was developed. And then it took over the anti-aging, like athletes who wanted to perform better. And we saw a lot of the negative side effects of growth hormone. But again, I want to bring Dr. Turner into this, and because she calls it the youth hormone. I used to call estradiol the youth hormone, but she calls the growth hormone the youth hormone, and it is the youth hormone because you only have it when you're young, and the moment it starts really going down, you feel horrible. So back to now excess. What will excess be caused by? Exogenous increase of taking growth hormone. The recombinant growth hormone that comes in the norepinephrine variety. So water retention, tingling extremities, arthritis pain, carpal tunnel syndrome, insulin resistance, thick skin, decreased olfactory sense, acromegaly, which is really the disease of too much growth hormone, and that's pituitary caused, and high cortisol levels. We don't really see this. I mean, I don't think I've seen it since I was in training, which was probably long before you guys were even born. So we don't really see excess growth hormone, but it's important to know what the symptoms and how it presents itself. Next, please. So here is a little bit about immunosenescence and therapeutics with growth hormone. So back to what happened in immunosenescence, your thymic involution, you're getting old, your hormones have left you. Growth hormone is the master youth hormone. So your increase in growth hormone acts in the thymus to increase T cell proliferation and development, which we just talked about, that the naive T cell development, I mean, just the availability of naive T cells doesn't exist anymore as we get older and we've gone past reproductive age. So putting back in the growth hormone, this study goes on to tell us what really happens. So it stimulates immunoglobulin production by B cells in an IGF-1 dependent manner, as well as increasing B cell differentiation. Growth hormone action also affects in the immune system, stimulating oxygen radical reduction by monocytes and neutrophils. Remember, we want the monocytes, we want the neutrophils, we want the macrophages, and growth hormone action helps us. It helps by promoting neutrophil adhesion and attracting the monocytes. Loss of growth hormone action resulted in this particular study in increased inflammation in the adipose tissue, further reinforcing the anti-inflammatory effect of growth hormone. And this is in the intestine of mice. But the point is that as growth hormone levels decrease, you wind up with all these symptoms of senescence, aging. And bringing in growth hormone changes that. It gives you back what you had lost. Next, please. So here are a few studies that show really what happens, that growth hormone increases lipolysis by increasing adipose tissue hormone-sensitive lipase, primarily in the fasted state. In another study, potency stimulates lipogenic glycerol phosphate dehydrogenase in differentiating pre-adipocytes with negligible effect on differentiated adipocytes. Lipolysis activated in the fasted state enhances amino acid uptake by the gut lumen, providing energy and precursors for hormone synthesis. Next, please. Deficiency is associated with increased risk for premature mortality due to cardiovascular disease. This is why, statins are not the answer. Hormones and peptides are the answer. Low IGF-1 levels are associated with higher mortality in older humans, study after study. And this is from 2018. Next, please. So let's look at a little historical perspective, because growth hormone is obviously a very important part of this, but we no longer need to use recombinant growth hormone that you get at the pharmacy, at the drugstore, but you can use a lot of peptides. And I will focus on the three main peptides that we use in the practice and just bring in two others a little bit, but make it easy for you to just start using peptides. So let's go back to see when the peptides show up. And I think that the peptides, what's very interesting is that peptides have been around a lot longer than anybody even knew about it. And so in 1902, Starling and Bayliss discovered Secretin, which is the water balancing peptide that's made by the duodenum. In 1931, but before it was Secretin was considered known as a peptide, we thought it was a hormone. So back to that distinction, right? 1931, it was discovered as a tissue extract that caused intestinal contraction and vasodilation in vitro. In 1953, the chemical composition of oxytocin, again, another X hormone or hormone peptide, was identified. Its amino acid sequence as well as synthesizing it. 1959, solid phase peptide synthesis was developed by Bruce Merrifield. And he got a Nobel Prize in chemistry in 1984 for this. So it was like almost 30 years that it took between what we now use for peptide synthesis as the regular way of getting it synthesized, which is the solid phase peptide synthesis. It took the guy it took science, I guess, or recognition, almost 30 years from the time it was developed. In 1965, scientists from China completed the synthesis of insulin, which was the first synthetic peptide. So there's a long history here of peptides being used and being researched. It just kind of took a long time to get to us, the medical profession, and the public. But rest assured, now the door's open. Next, please. So what are the peptides? So they're growth hormone-like peptides. So they're growth hormone, I'm sorry, not like growth hormone. They are growth hormone releasing peptides, which are very important. That's the ones that we use pretty much in everybody in the practice, and that's the ones we'll be discussing in detail. And so the growth hormone releasing hormones are CJC 1295, Moreland, Tessa Moreland. Ghrelin imitators are growth hormone releasing peptides, and we work with ipamorelin. Then growth hormone fragments are AOD, which is used in weight loss, mechanogrowth factor, modulation and repair of and growth hormones, thymosin beta 4 and follistatin, telomere activation. You know, you hear all the time about telomere extension with TA1, but epithelon actually is proven to do that, to activate telomerase. The melanocortin family, which are basically melanotan. So that's really the groups of peptides, the families of peptides. Next, please. So growth hormone and ghrelin. So this study told us about secretagogues of growth hormone interact with the ghrelin binding sites in the pituitary to promote release of growth hormone. So ghrelin is the peptide hormone that makes you hungry. It's called a growth hormone releasing peptide. Now, making you hungry is a good thing. It's not going to make you gain weight. It's actually an important stimulator of growth hormone production and release. So people mistake the need for diets, and they don't want to be hungry, and appetite suppressants are given to patients all day long, when in fact you want ghrelin to be stimulated, because ghrelin increases growth hormone production and release, which actually increases muscle mass and increases fat burning. So we have it kind of backwards if we don't really understand that. So ghrelin also has other very important side effects. It improves memory and aids with skill retention, and is neurotropic in its effect. And in this study, ghrelin directly stimulated adult hippocampal neurogenesis, implication to learning and memory. Next, please. So peptides versus recombinant growth hormone, which I already talked about, but I think it's important for us to realize that, you know, we still use some growth hormone recombinant, but the peptides are really taking the place, and they're doing great. Peptides stimulate the natural growth hormone secretion by the pituitary. They allow self-regulation of growth hormone secretion by the pituitary. They don't downregulate pituitary growth hormone secretion. Recombinant growth hormone does regulate pituitary downregulate pituitary growth hormone secretion. So it kind of stops your own pituitary. Now you could say, well, if you're old, you're not going to be making a lot of growth hormone, and how do you know that you will release growth hormone when stimulated with by the growth hormone releasing hormones? And there is a lot of scientific data to support the 180, 190, 200% increase in the release of growth hormone in people who are over 60. So I think that we're very good at seeing the importance of peptides versus the recombinant growth hormone. They're safe for long-term use. Now, I'm not saying that they started using them in 1906 when Secretin was found, but they've been used for decades, and there is no data against their long-term use. Next, please. So now let's look at the growth hormone releasing hormones and the growth hormone, ghrelin hormone releasing peptides. So CJC, ipamorelin, sermorelin, ghrelin itself, and Tessa Moreland. We'll look only at a couple of them because sermorelin's kind of fallen out of use a little bit. Ghrelin itself we're not using, and CJC, Erika Moreland, and Tessa Moreland are the mainstays of these hormones therapies. Next, please. So immunosenescence, remember everything we're doing is trying to get that immunosenescence treated. And within the heart, in this particular study from 2020, they found that you can use them in overweight and in obesity and type 2 diabetes. So within the heart, the growth hormone release agonists can activate cardiac repair. And this was in rats. And they saw that there is a signaling pathway on GHRHs in the heart to heal it, to actually improve the status of the heart muscle. Growth hormone releasing hormones agonists, and this is MR409, was demonstrated to suppress tumor growth of human experimental lung and other cancers. And peptides are being used more and more in therapies to support and protect cancer treatments and cancer patients. And when we get to thymosin alpha, we'll see how significant the peptides are in getting people getting chemotherapy to work better and to protect people from cancer tumor growth. And so there's a lot of promise in that area. Next, please. Ghrelin Ghrp, it regulates release of growth hormone release together with GHRH. It stimulates cardiac parasympathetic nerve activity via activation of the cholinergic anti-inflammatory pathway. And this is from 2019. And it decreases VEGF and VEGFR2, which create angiogenesis and plaques in ghrelin-treated rabbits. It decreases atherosclerotic plaque content of macrophages, the metallomatrix proteins, and pro-inflammatory chemokines. And this is from 2017. So basically what it's saying is that it decreases all pro-inflammatory and pro-carcinogenic. It's not in humans, but it's really important to keep that in mind as we go into the humans, which we will get to very shortly. Next, please. So GHRH have receptors on cardiac stem cells. They stimulate proliferation and survival, according to this study from 2014. They modulate genes involved in cardiac remodeling from 2015. In rats, after experimental MI, markedly attenuated the degree of cardiac functional decline and remodeled the increased anti-apoptotic gene expression through ERK1 and AKT phosphorylation. Next, please. So the most expensive and FDA approved peptide that is a GHRH is Tessa Moreland, and it reduces triglycerides and visceral adipose tissue. And this is from 2010. Now, if you think about the fact that people with increased visceral adipose tissue have increased cardiac events, they always have elevated cholesterol, triglycerides, lipid problems. This is a very interesting study that really showed you that Tessa Moreland reduces triglycerides and visceral adipose tissue. I mean, I don't want to beat a dead horse, but statins don't do that. And you actually are helping people by helping them decrease the risk factors rather than just decrease the number. So next, please. And this from 2008, from 2016, and this study from 2016, they consistently showed that GHRHs stimulate expression of major antioxidant enzymes. They restore GLP-1 actions on hyperlipidemia and hyperglucagonemia in rats. The pretreatment of transplant islet cells improves proliferation of metabolic function and facilitates engraftment. So again, GHRHs are the ultimate anti-aging, because what they're doing is they're helping the body, whether it is in the heart or peripherally, improve metabolic function, thus improving healing and correcting diseases, chronic diseases that develop over time. Next, please. So this study from 2007 again shows us how the GHRP, the ghrelin agonist, changes the phenotypic expression of adipocytes from white, which are inert and they don't burn fat, white adipose tissue, to brown adipose tissue, which is fat burning. Crucial part of how you could stay healthy. And I think this is very important. Next, please. So what's the number one growth hormone release hormone that we use right now is CJC. So CJC1295 increases growth hormone and IGF-1 secretion and effects. It has no increase on prolactin, leads to fat loss, increases protein synthesis. It can be used daily for natural growth hormone pulse, and it promotes slow wave sleep. Now, that's the type of sleep that's responsible for highest level of muscle growth and memory retention. And as you get older, how does Mother Nature take us out? We stop sleeping. Next, please. The CJC in the elderly, CJC stimulates pituitary gene transcription of growth hormone messenger RNA, increasing pituitary reserve. Because remember I said that before, that you would think that as you get older, you're going to get nowhere with growth hormone releasing hormones because the pituitary has no hormones, no growth hormone. But apparently it increases the pituitary reserve and thereby preserves more of the growth hormone neuroendocrine axis, which is the first to fail during aging. So this is really important to know, because when people want to administer growth hormone, recombinant growth hormone, they think that that's going to help people because as you get older, the pituitary has no reserves, and this way you're not going to have any growth hormone released. But as it turns out from the study from 1994, it increases the reserve and the release. So you have no problem getting growth hormone out from an older pituitary. Next, please. So CJC-IPA is the ipamorelin, is the combination we use the most. It's useful for boosting the family of growth hormone. An increase in growth hormone assists in wound healing, decreases inflammation, locally and systemically, increases integrity of the collagen substrates, improves mood, faster recovery from injuries, and maintenance of muscle mass and tendon integrity. These are crucial anti-aging pieces. I mean, the improved mood alone, if you think about it, changes the outlook, changes the person's ability to not become sedentary, to lose perspective of that there is a future. It gets people off the couch and gets them to move. And moving is really crucial to staying young, because you can seriously, we say that a lot. You look at a person and you know their physiologic age by the way they move. If they move fast and they get up from seating position and just moving around fast, it reminds you of the children in the playground. And children in the playground are young and they're full of energy and they move a lot. So when you stop moving, you're heading in the wrong direction. Next, please. So together, CJC and ipamorelin are formulated 2,000 UG per milliliter, and the dosing we work with is 0.1 milliliter. For patients who don't respond, which is less than 5%, and I mean, I'm talking about patients in their 60s and even 70s, we increase the dose to 0.2, which is 20 units. There is a pituitary fatigue factor that occurs with continuous dosing. So we recommend, and actually everybody who works with peptides recommends, that dosing be restricted to 5 nights on and 2 nights off to give the body the ability to not fatigue and stop working. Next, please. Tessa Moreland. In this study, they had 53 patients that were on Tessa Moreland for 12 weeks. There were no change in diabetic parameters, and you know that that's one of the fears that always existed with exogenous growth hormone because of the increase of insulin resistance that occurred in overdosing it, because it doesn't occur in people who just basically dose at physiologic levels. And there was a significant increase in total and non-HDL cholesterol. So this came from 2017, and it was a pretty good study because 12 weeks is a pretty significant amount of time to see the results. Next, please. So what is tesamorelin? As I said to you, is the only FDA-approved GHRH. It is approved for lipodystrophy in AIDS patients. It raises IGF-1. It reduces triglycerides. It reduces visceral adipose tissue, which we talked about the significance of it. It reduces carotid intimal media thickness. Improves cognition in people over 60, so it has a good nootropic effect. You don't have to give them modafinil. But it's very expensive. It's like $4,000 or $5,000 a month. And we started with a few patients on it, but then we had to give up because it was way too expensive. And their CJC-IPA was just as good a combination, and certainly in a very different financial realm. Next, please. The dosing it comes in little vials that are 1 milligram lyophilized, and you'll be constituted with 0.6 cc's of sterile water. You inject it subcutaneously, and it's always on the side. You know, I tell people on where their love handles are, but then they don't have love handles once they start using GHRHs and working out. It's before bed. You want their stomach to be empty. 1.5 hours after the last meal, and again, 5 nights a week. But we do that with all peptides. 5 nights a week is all we need. Next, please. So here's a patient. This is what we've been waiting for, right? So this is a patient. These are all patients in the practice. And they're really good examples of what we use peptides for. So now we're at GHRHs. So this is a 49-year-old male with fatigue, weight gain, losing muscle mass, can no longer exercise as he used to, lost his mojo, meaning some libido is gone, brain fog, and sleep interruptions, would like testosterone. And he was referred to us by some other patient in the practice who happened to be his wife. So he was 6 foot tall. He weighed 315 pounds, which was pretty amazing. Blood pressure was normal, shockingly. Cholesterol was 180. The LDL-C was 110. His triglycerides were 350. So, this guy was not moving. Well, I don't know how he could have moved with 315 pounds carrying on that frame. Fasting blood sugar was normal. Hemoglobin A1C was normal. All these things were shockingly normal. IGF-1 was 130, which is low. FT3 was normal. FT4 was normal. TSH was normal. Normal liver function test, renal function, EKG, CIMT. His body count, his percent body fat was 44, and his BMI was 32. So this guy is a young guy with really interesting that he's come in early enough that they're not significant disease state present yet. Next, please. So what was the diagnosis? Well, he had obesity, age-related changes. I don't know how I can say that because a 49 is still a young man, but there were age-related changes. He had dyslipidemia and low IGF-1. So what did we do with this patient? Think about this. Well, this is what we did with this patient. We gave him testosterone, of course, because that's what he came in for. We gave him CJC. And then we went really serious so we gave him a couple of weeks to feel better. And he started feeling better because this is really rapid. CJC may take up to 6 weeks, but testosterone gets you going very quickly within a week. And then you can get serious about the dietary changes because we don't really start people attacking them with dietary changes when they're in the position this guy was in. It was like, you got to make him feel better before he can actually even hear you about dietary, lifestyle, and exercise guidance. But of course he did everything else because look what happened. Next, please. At 3 months, he had lost 30 pounds. At 6 months, he had lost 65 pounds. Not so surprisingly, all blood parameters went to normal. He lost 8 inches from his waist, and his IGF-1 went to 340. So I guess CJ Moreland work. And his percent body fat dropped to 23%. And this is really a significant save as far as we're concerned. You're taking a 49-year-old that's on the downward slope of getting old and developing chronic disease, and you move him right off that slope into normal, healthy, optimum weight, optimum ability to work out, and change his diet and lifestyle. Next, please. So we'll come back to GHRHs soon, but let's add thymosins. So thymosins are biological response modifiers. Sounds very significant, and I'm sure you've heard about them. They're endogenous peptides that stimulate the development and differentiation of T lymphocytes. Remember, T lymphocytes, thymus, crucial. They play a role in regulating the immune system by stimulating other kinds of immune cells as well. And there's several factors that control the release of these peptides, including the presence of foreign organisms, viruses, bacteria, etc., chemical messengers from white blood cells, levels of pituitary and other hormones, for instance, ACTH, cortisol, estrogen, testosterone, and nervous stimulation. As you see this, complicated, I'm sure you've seen this before, everything is like circular. You have stimulation, and you have blocking, and they all affect everything else. So there's nothing in our body that doesn't interact with absolutely everything else, whether it is at the cellular, molecular level, or at the larger organic brain body level, everything interacts. Now, thymosins are crucial, and growth hormone, release hormones are crucial, but this is the next level crucial. So next, please. I will only address thymosin alpha-1 today because my goal at the end of today is that you go back to your practice and you start using peptides. literally on every patient, because the changes are remarkable and the need for them is remarkable. So thymosin alpha 1, it was the origin of thymosins date back to 1961, when it was shown that neonatal thymectomy had several severe consequences on the immunologic capacity of newborn animals. So what happened was that they removed the thymus on these newborn mice, and they basically died very quickly because immunologically they were gone. And then they put them back. They put the cells in a cellular, like in a little bag that did not allow the cells to come through, and the thymic cells. And they realized that these mice started surviving, and they had better immune capacity, and actually their immune capacity was fine. So I think that what that was when it was isolated by Alan Goldstein in 1977, and they realized that there was something that was not the cell, but something in the cell of the thymic cells that improved immune capacity. So there it is, the 28 amino acids, or prothymosin alpha, the N-terminal acetylated form. So that was thymosin alpha that was found in 1970. Next, please. So it's a synthetic thymic peptide. I mean, it's endogenous because we have it, but we make it now. 28 amino acids, and it modulates innate immunity, and it's pleiotropic. Next, please. It's a major component of thymosin fraction 5. It's responsible for restoring immune function, particularly cell-mediated immunity, which is crucial, right? Increases major histocompatibility complex and toll-like receptor expression, increases cytokine production, so it has an immunoregulatory role. Next, please. It works against the inflammatory state of senescent cells. So again, we're going back to senescence, aging. How do you get rid of these cells, or how do you improve the ability of every other cell around them to ignore their horrible messaging? So TA1 is a direct senolytic agent that supports apoptosis, meaning kill themselves, to senescent cells. It upregulates glutathione. It promotes and improves cellular redox. It initiates IL-10 transcription, improving seromodulation. It takes away the camouflage trick of senescent cells that used to hide themselves, and has a direct application to cancer cells because it improves the ability of natural killer cells to eliminate the cell. And we gave a talk, our group gave a talk at the Lymphoma Leukemia Society about the use of peptides in cancer. And this is one important role of thymosin alpha, that, senescent cells behave just like cancer cells, essentially, well, from the standpoint of hiding themselves. And thymosin alpha removes this camouflage trick. Next, please. So it supports an anti-inflammatory state. And that's really the most important piece, 2012. It supports apoptosis. Let these cells kill themselves. We don't need them. It upregulates glutathione, same as the other study showed you before. Promotes and improves cellular redox. Improves natural killer cells to eliminate cancer cells and senescent cells. Immune boosting. It delays cell senescence. Next, please. Maintains immune homeostasis. It stimulates immune response. It decreases, there is a decrease in thymosin alpha 1, cytokine, chemokine, and protease responses. It upregulates glutathione, the same as the studies I showed you before. maybe in a way, it was somehow the fact that our patients have been taking thymosin alpha through the whole pandemic that led to so few positive COVIDs and no hospitalization in any of them, because the immune homeostasis in these patients is so good because of the thymosin alpha. So age has not led to a decreased immune function in our patients, because how else do you explain it? Of course, they're all on hormones, they all take care of themselves, but you need the immune response has to be really good in order for these patients to fare as well as they fared so far. Next, please. Why are we deficient? Well, because cellular senescence leads to mitochondrial slowdown, as the study shows us. And it's from the guy who initially identified it. Age and loss of cell efficiency, metabolic decline, NAD to NADH. Thymosin alpha restores immune function to the thymus and in cells entering senescence. Next, please. Here's another one from 2017 that tells us of the use of thymosin alpha in diseases. So it's being used in the George syndrome and treatment of hepatitis B and C, treatment of HIV/AIDS in conjunction with oral antiretrovirals, to improve the press response to vaccinations and other chronic illnesses. And for 1 second, let me digress and talk about the vaccinations, that now everybody is being encouraged to be vaccinated. And we see no responses in older people because their immune system is so low that they do not respond. And I've had patients in the practice that took the vaccination, and these are patients who are really optimized, right? And I had these patients that 2 weeks after the first vaccine, 4 weeks after the second dose, wound up, we measure everybody's antibodies and T cells, and I'm keeping track because we want to publish the data. And the interesting thing is that they're patients, and these are patients, the ones who are immunologically more depressed, because they take the hormones, they take the peptides, but they don't really take care of themselves. I mean, there's been a lot of increase in alcohol consumption, a lot of weight gain, a lot of less working out that went on in the past year, and we all know why, because it's pretty difficult mentally on all of us. So what happened was that these patients, they have patients who have had no increase in immune response. And these are people who are taking, support, immune support. So can you imagine people who don't do anything and that are older, that the response to vaccinations may be disappointing? So that's why we need peptides and hormones. Next, please. So what are the clinical effects? It used in Lyme, chronic fatigue, reverses immune suppressive evasive effects of Lyme, increases, as we said, NK cell activity, IgM, IgG conversion. It's antifungal, increases antioxidants, including glutathione production, inhibits viral replication, increases expression of viral antigens on the surface of infected cells, HIV, HPV, HSV. It blocks steroid-induced apoptosis of thymocytes. Next, please. So what's the dosing? It has a 2-hour half-life. In acute phases, like treatment for viral infections, acute, when people have the flu or they get sick and, viruses, people with HPV, Epstein-Barr, we work with them they do the viral infection for like treatment for 2 weeks every third day, 3 months or longer for more complicated cases. Otherwise, we do it when they come and have their IVs, and we do it IV, or they just take it at home 5 nights a week. With inflammatory joint disease, we do 6-week cycles or match the immunosuppressants. So steroids, methotrexate, Plaquenil, biologic agents, Humira, Enbrel. These are kind of, we're balancing the negative side effects of them. So here's patient number 2, 52-year-old female with recurrent infections, UTIs, URIs, skin rashes, allergies to various foods and environmental factors, sleep issues, weight control issues, in spite of a regular workout routine, bloating, irregular menses, brain fog, loss of libido. The kitchen sink. We see this all the time. Her past medical history, non-contributory. She's had extensive workout of immune function, a lot of GYN exams, a lot of doctors being involved. The problem is that nothing ever bears fruit because we never come up with diagnoses that address the root cause of the problem and help the patient feel better. So she has regular mammograms, ultrasounds, and PAPs. Her height is 5 foot 2 inches. Her weight is 153. Her blood pressure is normal. Heart rate's normal. Her labs are mildly elevated cholesterol and triglycerides. Her TSH is 3.2, which would be considered normal, but it's not. Estradiol testosterone levels are low because she's menopausal. Mildly elevated homocysteine and CRP, which is our inflammatory marker, so that should mean something. Percent body fat, 45%. That's really serious. Nobody should walk around with a percent body fat of 45%. Her BMI is 31. Next, please. So what's wrong with this patient? She's menopausal, she's hypothyroid, she's got chronic inflammation and immune imbalance. This patient is your classic patient that we see every day that gets treated with antidepressants, that we look for Lyme disease and chronic fatigue, that we give it all kinds of junk to, who are so easily taken care of. It's pretty sad that not everybody, like every patient you go back to see this way, treat them this way. Next, please. Treat them with testosterone, estradiol, progesterone. Find out if they need estradiol and progesterone. I mean, they need progesterone. They probably need testosterone primarily. And find out if they were, they have children and they were pregnant, then you will find out if they need estrogen or not. Because if they felt great when they were pregnant, they probably need estrogen, estradiol only. And if, the only estrogen I would discuss. And if they felt horrible when they were pregnant and prefer not pregnant, then give them testosterone and progesterone. Give progesterone to everyone. They'll feel like different people. Thyroid, unequivocally, they'll feel great on testosterone, progesterone, or testosterone, estradiol, progesterone. But thyroid, do not forget thyroid. Her TSH is 3, but I don't even need that. She is overweight. She's sluggish. She's got all these issues that are thyroid related. Adrenal support, give her adrenal support. CJC and IPA, thymosin alpha, unequivocally. The results will amaze you, but don't start everything at once. Start with one thing at a time. Like I'd start with the thyroid first, then having talked to her, figure out if testosterone, progesterone go next, or estradiol, testosterone, progesterone. Then add the peptides and see what happens. Next, please. So this is what happens. You also make sure that diet, exercise, and lifestyle and stress management and sleep are crucial, integral parts of this. We don't just do the hormones and the peptides. We take care of the whole patient, and you take care of the whole patient. So if you put the pieces together and you start slowly and you do it over a course of a couple of months, the results amaze you over and over again. In 3 months, she had no more infections. She lost 10 pounds. She felt like she was 35 again. In 6 months, she had no infection. She lost 20 pounds. She felt great and is now productive and happy. At 3 years, we added more peptides, took a break from some, and also adjusted hormones as she entered menopause and needed more care. And at 10 years, she's still doing great. She has no complaints, still on hormones and peptides, supplements, and constant tweaking of lifestyle, workout, diet, regimen. This is not an unusual patient. This is our typical patient, and I'm sure it's your typical patient too. Next, please. BPC 157, the next peptide. It's the body protective compound. Next, please. So BPC, and I'm going to move through this quickly, from 2016, is a tissue healing and wound healing peptide. It may counteract the consequence of dopamine-related neuronal damage. It helps with serotonergic system and may be at least partly related to a rather specific counteraction of 5-HT2A receptors. It reduces regional rate of serotonin and enhances it. So this is about the brain-gut axis in 2016, BPC 157. Next. It's has an antidepressant activity, and this is from 2016. Traumatic brain injury counteracts the progressing course. It supports homeostasis of the GABAergic system, upregulating the GABAergic neurotransmission, has a modulatory effect on dopamine system, could be used in both acute and chronic amphetamine disturbances, could be a particular antagonist of alcohol effects, and it's a dopaminergic effect on opioid. Next. Next, please. Significant anti-inflammatory modulating effects. Promotes tissue healing through signaling pathways. It's a peptide. Upregulates gene transcription to influence these healing factors. This peptide has no primary effect. It's all about signaling. Peptides are about signaling. Next, please. It influences tendon repair, muscle repair, intestinal repair, bone repair, teeth repair, brain repair, cornea repair. It upregulates growth hormone receptors. It's an amazing peptide. Next, please. The dosing sub-Q, half-life is 4 hours, but it counteracts corticosteroid effect on muscle. The good thing is, in our practice, we use it orally, 500 micrograms daily. Acute phase maybe 2 a day, otherwise 1 a day. This is from 2010 on muscle healing impaired by corticosteroid application. Next, please. Patient 3, a 56-year-old male with fatigue, sarcopenia, weight loss, reduced exercise capacity, subclinical depression, low drive and motivation, brain fog and malabsorption, diarrhea, bloating, floating, foul-smelling stools. Extensive GI workup revealed pancreatic insufficiency as possible source of malabsorption, nothing else. 6 foot tall, 175 pounds. His body mass index is 27, low. Percent body fat is kind of high-ish, but not 29%, not really. He's got in the labs just a borderline amylase. His TSH is 4.0. So here's a thin guy with low thyroid. His testosterone, of course, is low. His CAT scan of the abdomen was normal. Colonoscopy, endoscopy just showed flattened mucosal epithelium. Stool testing was all negative, except for malabsorption. Next, please. So he has malabsorption, low testosterone, hypothyroidism, sarcopenia, and weight loss. Not a good combination. Next, please. So we gave him testosterone, his testosterone was low, CJC-IPA, thymosin alpha, BPC 157, We changed his diet to a diet that's all cooked vegetables, no raw vegetables. Remember, we got to rebuild his gut. Exercise regimen and sleep. We increased the amount of exercise. He was very sedentary, and as he started feeling better, we added exercise, started to build muscle because he had no muscle. Next, please. 2 weeks later, the malabsorption syndrome symptoms totally resolved. 1 month, he gained 5 pounds. 3 months, his muscle mass significantly increased. 6 months later, he was much improved. And a year later, he's still doing very well. And malabsorption only acts up when he eats the wrong things, or he drinks alcohol or caffeine. Next, please. This is very short. Dosage on AOD is a fat loss protein peptide. We use it in patients who want to lose weight. And here is how you do it, basically. Next, please. Patient number 4 was a 34-year-old female with 20-pound weight gain, para 3003. Last baby, age 3, has been trying to lose weight unsuccessfully with diet and exercise, had gone to a lot of doctors who gave her phentermine, thyroid, and Ozempic, and all kinds of medications aimed at getting her to not eat, but she wasn't really eating a lot. She had no past medical history. Everything was normal. Her percent body fat was 45. Next, please. So she was obese. That was it. Next, please. So we gave her AOD with CJ-CEPA, and we talked about diet, exercise. She was doing a lot of aerobic exercise, and we just recommended that she start doing weight exercises, weight bearing, weightlifting, build muscle, and with the CJ-CEPA, that would do it. And the AOD would help her lose weight too. Not that the CJ-CEPA wouldn't. Next, please. A month later, she had lost 10 pounds. 3 months later, she had lost 20 pounds. 6 months later, she's doing great, and she's still on CJ-CEPA. Next, please. One more, melanocortin receptor activity. Melanotan-2 stimulates melanocyte production of melanin. There are gut receptors for both peptides, leading to loss of appetite and even vomiting in extreme cases. So it's about the dosing. And the people that we get usually for melanotan are all the same. Next, please. For tanning, you start very slowly, and then for metabolic support, you do it, 5 to 10 units sub-Q. Also works for immune support, but we already have the CJ-CEPA and the thymosin alpha at this point, so you don't need to add this. The only thing to add the melanotan for at this point would be for tanning. And if you want to do it for any kind of metabolic support, just do it once or twice a week. Or next, please. So here's the patient, typical patient, 43-year-old female with history of burning, not tanning, wants to get tan and has no medical issues, has heard and read about the melanotan that she could order it online, but prefers to work with a physician. She's a friend of one of our patients. So of course, we did this. Next, please. So she got melanotan for 2 weeks, then weekly for 1 month, got her tan, went to the Caribbean. That was before COVID, didn't burn and had lots of fun. And then she stayed on melanotan weekly to maintain her tan, which she said never before had she had a tan for so long. Next, please. And last patient we have is kind of the embodiment of why I'm still doing this, why I love it, and I will continue doing it, and add new layers as time goes by of new ways to help people optimize their lives. This is a 52-year-old female. She presented to Evolve Science, which is our practice, 4 years ago with ulcerative colitis on Remicade for 20 years, status post-hysterectomy for fibroids, opiate user for 15 years, hot flashes, fatigue worse than 3 p.m., has to lie down, weight gain, cannot work out due to pain, used to be a bodybuilder. She can't sleep well. She sees a naturopath who placed her on thyroid, astragalus, bovine, beef liver, collagen powder, L-glutamine, L-tyrosine. She used CBD daily for pain in the knees and has weekly IVs with phytoestrogens and lipotropics. I could never figure out what was in that. She was overweight. She had upper body wasting, a lot of abdominal fat. Her percent body fat was 47. Her visceral fat was 15. Her BMI was 35. She had low estradiol, low testosterone, low thyroid, high FSH, LH. LFTs were borderline. Next, please. So she had ulcerative colitis, osteoarthritis, hormone imbalance, hypothyroidism, sarcopenia, depression, and drug dependency. Next, please. So what happened? This was in 2017 when she first started. We started her on thyroid, testosterone, estrogen, and progesterone, estradiol and progesterone, transdermal. She actually took estrogel, which is FDA approved, supplements, which is part of another lecture, diet, exercise regimen, detox from opiates, and sleep. Next, please. So she felt better immediately on the hormones, the thyroid and the adrenal support, diet, exercise, and lifestyle coaching. At the end of the first year, we added CJC-IPA, thymosin alpha, and BPC. In year 2 and 3, we saw gradual improvement and went back to working out and weightlifting. Remember, she was a bodybuilder years before this started. Year 2.5 had an autologous adipose stem cell injections into her knees. Year 3 to 4, she alternated CJC-IPA with recombinant HGH, like maybe 2-3 times a year, HGH, then CJC-IPA. End of year 4 on peptides and hormones and stringent diet and exercise and sleep regimen. She's doing amazingly well. Next, please. Her BMI was at year 4 plus was 20, her percent body fat 18. Her bloods were all normal. She's pain and drug free and happy with her life. And here are some pictures of her. Next, please. This is on the left. You have in 2018 when we started. And this is 2020 on the right. Next, please. This is in 2020. Next, please. This is a video from this week that you sent to me in preparation for the lecture because you wanted to share her success with you. Next, please. Next, please. This is all for literally last week. Next, please. That's her. And she wants you to know that she feels great. And she is an amazing woman. It takes an amazing patient, but it takes a lot of help from, it takes a village. So peptides are really great if you know what you're doing, if you listen to the patient, if you put them together with exercise, lifestyle, stress management, diet, sleep, and of course, hormones. Thank you so much, and I'll be happy to answer any question, and thank you for the opportunity. Thanks.